Good morning. This is a lecture on the blood count, complete blood count, which is called a CBC. And here we just want to get the general basics. This is a blood count of a lady age 65. And here you can see that why isn't it going forward? Okay, you can see here that the white count here is 4.8 thousand cells per microliter, and here is the which is the reference interval, and you can see that it's normal. It's within these parentheses. Now note here that she complained that she was worried that the fact that she had a value of 4.8, and although it was within the reference interval, that nevertheless it was before around 7.5, and therefore she was worried that she was getting too low. Now, she was relieved when we explained to her that the white count is very variable, which is called biological variation, and that as long as it's within the reference interval, there's nothing to worry about. Some of the white cells, like the neutrophils, for example, have a very short half-life of around 7 hours, and all these things can increase and decrease according to the viral infection or just general exercise or other things. Note that her neutrophil count, which are cells that fight infection, are also close to the bottom limit of the reference interval. The absolute count, however, is what's important for neutrophils, and you can see it right here. And the absolute count is over 1.8, which is the lower limit of the reference interval. However, you don't have to worry about the neutrophil count absolute until it gets to less than 1,000. Usually in patients who are getting chemotherapy, and then there would be an increased risk of infection. Usually in that case also, when you are getting chemotherapy and it goes down under 1,000, although there's an increased risk, there's really nothing to do unless you have fever. Even usually you don't get fever even if the neutrophil absolute count gets less than 500. Now, the neutrophil absolute count is made up, as you can see, of the white blood count times the percent of the neutrophils. These are the lymphocyte count. She had 43, which is above normal, above the reference interval. Also, there's nothing really to worry about. What you look here also is the absolute count. And you can see here that the absolute count is within normal limits. The only thing that you can look at that's important as far as the lymphocyte absolute count is when it goes over 5,000. And then if this continues for 6 months, this could be because of what's called chronic lymphatic leukemia, CLL. This is a disease that's not really important to diagnose early, and today, once the lymphocyte absolute count goes over 5,000, or 5.0 thousand per microliter, that's when it becomes that you can do a special test and diagnose CLL if you want to. The next thing that we want to talk about is the LUC percent that you can see here, which is large unstained cells percent. This is a value you won't get with all analyzers, but you do get with the analyzer that we use. And these are large cells that are not stained with myeloperoxidase, an enzyme that is found in the granulocyte line, the neutrophils sign, and this is a sign that this is an important cell because it can be the first sign of acute leukemia. Once this goes over 5%, we look at the blood smear looking for immature cells. Although the reference interval here is 0 to 7%, this varies according to age, and a very high LUC can also be found in young infants. Otherwise, besides the LUC, you can see there are monocytes, monocyte absolute, eosinophils, absolute eosinophil count, basophils, and absolute basophils, which all were within the normal reference interval, what some people call the normal reference interval. Now let's go to the red cells, and here we can see that we have an RBC, which is 4.39 million cells per microliter, which is within the normal limits. We also have a hemoglobin, which is how you define anemia. If in women, if it's under 12 grams per deciliter, or in men under 13 grams per deciliter, these are often what's considered anemia, very mild anemia. And she had a normal hemoglobin. Besides that, there's what's called a hematocrit, which should not be used today. Hematocrit is actually the RBCs, the number of red cells, times the volume of each of the red cells, the average volume, which is the MCV. And that actually, using those two values, you don't need to calculate the hematocrit. There is a use for the hematocrit, which we will see later, but not clinically. It's not important. Once used to use it because it was measured. You used to centrifuge the blood and then have the proportion of blood that would, the portion of red cells that you could see, the solid red cells, and the proportion of liquids. But today it's really not important, and you should just look at the hemoglobin and the MCV. After that, you have some indices which also should not be used today because you have better measures than what they are, what's called the MCH, mean corpuscular hemoglobin, and the mean corpuscular hematocrit. And this can sometimes, the MCH was used to diagnose a rare disease called hereditary spherocytosis. But today, at least with this analyzer that we use, we have a better measure than these average values. After that, there's what's called the RDW. The RDW is the red cell distribution width. And classically, people have thought that this can be useful in diagnosing iron deficiency anemia, which is not true. It's not a very good measure of that. It can be normal in iron deficiency. It can be elevated in other things that have a microcytic anemia. Note here that that when we talk about the different types of anemia, that the MCV divides these types of anemia into three types. If it's over 99, then you talk about big cells or macrocytic anemia. And if it's under 80 or 78, you're talking about small cells or microcytic anemia. And all the others in between are called the right size cells or the normocytic anemia. This is very important when you're trying to differentiate why somebody, what type of anemias could be, and that's important. But we have now something that's better than the MCV as classifying the cells. And here you can see that you have macrocytes, the number of big cells, microcytes, the number of small cells, hyperchromic, the number of too much hemoglobin in the cells, and hypochromic, the number of cells that have too little hemoglobin. The macrocytes, you can see here, are elevated somewhat, and this is because you can see here the MCV is close to the upper limit of normal. There's really nothing to do with this at the present time because she's really not suffering from anemia, and perhaps only you may suspect B12 deficiency, and in that case, a B12 blood level will not be helpful. But if the patient is asymptomatic, they probably should do nothing. If there are any symptoms that suggest B12 deficiency, vitamin B12 deficiency, then a trial of B12 should be given, even if the blood level of B12 is normal. This can be done orally, and then and then just to see if she responds. If she doesn't respond, then this, of course, has no significance. Unfortunately, the B12 test, when people that have this B12 deficiency, pernicious anemia, is normal in 25% of the cases. So really, you need a trial of B12 to actually see if this increased macrocytes are due to B12 deficiency. However, if the patient is asymptomatic and they just sent this as a routine screening test, which probably should not be done in most cases, probably nothing should be done. The microcytes and the hypochromia may be indices used. Microcytes are found in two situations usually, most commonly iron deficiency and what's called beta thalassemia minor. And the hypochromia is probably the most sensitive index. This has not been well worked out, but it increases if you have you don't have enough iron. This can increase before the MCV decreases, and might be the most reliable screening test for iron deficiency. There is a way, if you take the microcytes, are usually more increased in beta thalassemia minor, a congenital condition, where the hypochromia is more increased in the iron deficiency. If the hypo is more than the micro, that suggests iron deficiency, and if the micro is more than the hypo, that suggests beta thalassemia minor. However, often you have a combination of the two, and then it's really impossible to differentiate, and you probably need to give a trial of iron. The hyperchromia is not often used, but I had a patient that had about a 20-30% hyperchromia, and this was for a rare condition called hereditary spherocytosis. Probably the patient would have been diagnosed anyways because this was a chronic anemia, and the appropriate test to send were to test the membrane of the red cells, and this was done, and the patient had hereditary spherocytosis. So although this may point out somebody who might have hereditary spherocytosis, probably the diagnosis will be made due to other factors. There is another, the index where I said the hematocrit might be important. And what happens here is if the hematocrit divided by the hemoglobin should be around 3. And this just helps us determine when we might have a problem with the analysis. Sometimes the hemoglobin may not be accurate because not enough blood was entered into the analyzer. And this we would be able to find out by these indices that would not be between 2.7 to 4.0, and the blood should be rerun. On the other hand, there's also a condition where you have cold agglutinants, things that take the red cells and agglutinate them together, and in this case also the blood can be warmed, and then you can get the correct answer. Platelets, her were 190,000. Note here that the lower limit of our reference interval is 100. Now this is a clinical reference interval. Most labs have used 140 or 130 or 150 even as the lower level of the reference interval. However, it's only significant if it goes under 100, the platelets. In this case, we also check for clumping of the platelets, which can give you a false low value. So really, in this case, it is more logical, in my opinion, to use 100 as a lower border of the reference interval. Otherwise, if you use higher levels, then you should probably be looking at the blood smears in all cases to rule out clumping. And then again, what will you do if you find clumps? It's not really clear. It's not going to change any medical decision. At least it shouldn't change any medical decision making. Now this patient, for some reason, they sent a hemoglobin electrophoresis to look. This is hemoglobin A2 is increased in a congenital condition called beta thalassemia minor. I don't know why it was sent. She had a normal MCV, and there really is not indicated to send this test. And as you can see, it was normal in the reference, within the reference interval of 0 to 4.0%. Also, they sent a reticulocyte count, which was 0.6%, which was also within the normal reference interval. The normal reference interval, often for reticulocytes, depends on the analyzer, and we have recently increased our level to 2.5%, which is accepted for the analyzer that we use. So these two tests shouldn't have been done. This is a first the first general lecture, and I will continue to give other lectures. Our next subject will be normocytic, normochromic anemia. And after that, we will go over microcytic anemia, macrocytic anemia, and then talk about white cell blood disorders and platelet disorders, and that is what we will do. Thank you very much.